I'm Dr Jam Kothari.
And I'm Dr Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Morning, Jam. Nice to see you. Here we are, another podcast, and I'm excited about today's podcast because we're going to be talking about treatment. It's kind of a subject we haven't delved into yet, and I think that's partly because it's a whole massive world, isn't it, for us to explore. But before we launch into that, what's up? Tell me your news. How's it going?
All good, Sally. The year's motoring on and lots been happening. So, all good on my side. Doing a bit more ward attending in a few weeks' time. Clinics are busy and potentially new drugs becoming available soon for NHS patients. So, exciting times. How are things down in the West Country?
Yeah, West Country's wet. Typical bank holiday weather, soggy feet, spuddling around in the mud here, but no, otherwise okay, thank you. Yeah, just enjoyed a few days off, which is joyous, but now back in the thick of it.
So treatment, I mean, a lot of the earlier pods have in a way set the scene because of course, people with active cancer, unfortunately need treatment. And we're going to focus today on the first line treatment. So when people have been diagnosed and they have active myeloma, they need treatment. And we're going to talk about, I think philosophically really, the aims, what it means. And as we go on, it will lay the foundation for further more detailed podcasts about specific types of chemotherapy. And we're going to talk about things like stem cell transplant, maintenance therapy, induction, and I'm using a whole bunch of words that are used so often, and a lot of the time people are not sure what these things mean. So hopefully this pod will set the scene and then we'll be able to build on that in the coming weeks.
It's tricky, isn't it? We're so familiar with the terminology and you forget that when you're new to living with myeloma, that what we say might sound like total gobbledygook. So I hope this podcast can sort of unravel some of that and allow us to provide a degree of clarity and just illuminate those sort of areas where it might be a little bit more confusing at times.
Because I think actually in essence, it can be simplified down. And I think sometimes the words are confusing, but the essence of what we're trying to do is actually straightforward. And I think hopefully that will come out as we discuss today. When we think about the first line treatment, I mean, very broadly, what are the aims of the chemotherapy drugs that we give? What are we trying to do?
All the treatment that we're offering people, the intention, the aim of that treatment is to calm down or control the myeloma as best as possible, and then to keep it under control for as long as possible. If we reflect back on that first podcast we did, Jam, we tackled that really thorny issue of is there a cure? But until there is a cure, and we're not there yet, I think this is all about controlling the disease to enable people to carry on living their life. And that's broadly the aim of treatment. Calm things down, keep them under control in a nutshell.
What I often say to my patients is we have an early, medium-term and long-term goals with your therapy. The early goals are try and get control of the damage to your organs as quickly as possible to stop further damage and hopefully improve the organ function. The medium-term goals are to continue that treatment and allow people to get to good disease control, or what we call remission. And then the longer term control potentially is different for different groups of people, but ideally you want to keep the myeloma with the first treatment that you're using, you want to keep the cancer under control for as long as possible.
And all the while that the cancer's under control, what we tend to see now is that people continue on treatment during that period of time, albeit a modified treatment, so not so many drugs and maybe not the same doses. And they're also being monitored so that when the myeloma does eventually re-emerge, other treatments can be offered. And that's kind of how the myeloma waxes and wanes over time.
So the first bit of treatment that people get, we often call induction. I think we need a little sort of couple of minutes of a history lesson. As we know, myeloma traditionally and more commonly is a disease of more elderly people, with maybe 2/3 of patients being diagnosed over the age of 70. So treatment has evolved slightly differently for our older patients compared to the third of patients who are diagnosed broadly under the age of 70. Can you just expand on that a little bit, Sally?
Yeah, well, the first thing I really want to point out is, we're not ageist. This isn't purely about age, but age can help you figure out what the right approach might be for somebody. And that's because if you're living with this condition, you want to live well with it. And so we don't want to offer really strong, punchy treatments, which could potentially cause problems to an older person who might be less able to cope with them. And so we do crudely use age to discriminate or sort of lump people into different categories. Now, that is a challenging approach and it deserves to be criticised. But what we're kind of thinking about there is how well is this person's heart working? Are their kidneys working? Is their body working overall to enable them to tolerate the treatments to get the best response? And so we do separate people into these different groups, but hopefully, particularly with people between the ages of, let's say, 60 and 75, there's a conversation there in terms of what the preferred approach might be for that person and what our thoughts might be on that as well. But the aims of treatment overall are different combinations of drugs, and it's also interesting or noticeable that the drugs that you use to bring about that initial disease control in the short term that you referred to, Jam, tend to be the same regardless of your age. And it's just what you do afterwards that might be different.
There are major classes of drugs and combinations that we use, and there are usually combinations of 3 or 4 drugs that we use in combination. And they are similar or variations of similar drugs that are used in sort of either group of patients. I think you very correctly say that, age is not the only discriminator at all, but there is a treatment approach for what we say the younger, fitter, stronger patients. Broadly, those patients are usually under 70, but there will be a patient of 60 that won't be suitable, and there'll be a patient of 75 that you think, absolutely, you're in this stronger, fitter, younger category. So biological age is only a part of this, and I think thank you for highlighting that really important point. So there is a sort of treatment approach for that group, and then there is a slightly different, less intensive treatment for older patients who may have picked up other health problems and are less able to withstand certain types of treatment. I mean, in both our clinics, we treat people in their 80s, late 80s, 90s even, and clearly how you treat a 90-year-old is not going to be the same as how you treat a 40-year-old. But as you say, the classes of drugs and things like steroids and other types of drugs, which we will be getting into in lots of detail, such as what we call the immunomodulatory agents, antibody drugs, drugs called proteasome inhibitors. Combinations of these are used in both groups of people. But Sal, let's start with maybe the patients who are able to have more intensive treatment. So if we think about younger group of patients, our aim for them is to control the disease initially, try and reverse any organ damage or minimize further damage. And then we're trying to get their myeloma to an undetectably low level as possible.
And keep it there, importantly, as well. And keep it under control, hopefully for many months, if not years. And that's very much our plan.
What does that look like? How is that treatment built? Because there's certain blocks that have specific names. So how do we name them, and how does that treatment pathway look to our patients?
So let's take a step back. For younger people, that initial period, let's say the first few months when you're starting treatment, is what we would refer to as the period of induction. And during that period of induction, which let's just say for the sake of argument, that's 4 months, you have blocks of treatment, which we refer to as cycles, which tend to last roughly a month. So you might have 4 blocks, so 4 months of treatment before you move on to the next part of your treatment pathway. Those blocks, or let's call them cycles, are composed of different drugs. And in the UK at the moment, each cycle now consists of 4 different types of drugs, which you receive at different times during those 4 weeks. And some of those drugs are tablets and some of them are injections under the skin. So that requires taking tablets at home and also coming into outpatient facilities, chemotherapy suite, to receive these injections under the skin, and of course follow-ups in clinic as well. So it's quite an undertaking. It's a lot to remember. Got to take tablets at home. I've got to turn up, see my doctor in clinic. I've got to turn up for my injection. It's quite a busy time, but it does get easier as you work your way through these cycles.
Yeah, so it's about 16 weeks, and broadly your injections are given once a week, and you'll have your bone strengthening injection once every 4 weeks alongside that. So that initial period lasts 16 weeks, and then people normally have 4 weeks off. And then we enter a part of the treatment where we do something called stem cell mobilization and stem cell transplant. Now, stem cells are cells that we all have that live inside our bone marrow, and they make all the cells that we need to function as healthy human beings. There is a technique that allows us to take them from the body, store them and freeze them, and then do something called a stem cell transplant, which is going to get a whole podcast on its own. But essentially, it's a way of giving a different type of powerful chemotherapy to try and further control the myeloma and get the cancer level down to a lower level, and hopefully a level where it's undetectable. So as people are going through from day one, we are monitoring the response to treatment by looking at the protein levels in the blood, the paraproteins, and the light chain levels, these protein fragments. And because myeloma produces these proteins that you can measure in the blood, that's a very good way of seeing if the cancer is responding. And people will be having other tests at certain time points to ensure that they are responding to treatment, such as scans and bone marrow biopsies. But Sally, the stem cell transplant is to push that response down even lower, isn't it?
Definitely. So once you've collected these stem cells, which I refer to as the parent cells, they sort of give birth to the other cells in the body, to put it crudely. Once you've collected these cells, which again we'll talk about in more detail perhaps in a few weeks' time, people are then admitted to hospital for a period of time, and they're given a different drug, which they haven't had before, called melphalan. And that really really calms down the myeloma within the body, but it also has an impact on healthy blood cells. And so in the process of doing so and affecting those healthy blood cells, you need to help the body heal. And that's where those stem cells or those parent cells come in handy, because you actually give them back to a person to help them heal from this newer drug they've received, the melphalan. That's a transplant. I think when you talk about transplants, people always think about, getting a new kidney or a new lung and something coming from somebody else. This is different. Basically, what we're talking about is just enabling people to have a different type of drug in a really big dose, but to be able to cope with it. And to cope with it, we use this clever technique of taking out these stem cells or their parent cells before they have the drug, and then giving them back to them when they need it to help their body heal. And that then, as you say, Jam, allows you to get rid of as much of the myeloma as possible and really, really calm things down. What we would refer to as deepening the response.
And often we have thought of myeloma as an iceberg, with the cancer that you can see above the waterline as the proteins that you can see disappearing in the blood. But things like the transplant allow us to get to very bits of disease that are under the surface and allow us to what we call deepen that remission. Because for our younger patients who are able to tolerate this stronger treatment, we know that if you get the disease to an undetectably low level, and as you rightly say, Sally, not just get it there, but keep it there, that is something that we know leads to very long periods of remission, with the disease being really well under control and hopefully not detectable. The transplant happens, it's broadly 3 to 4 weeks in hospital, and then there is a recovery period after that. And then, Sally, there's another block of treatment that is traditionally given after that called consolidation.
Yeah, we don't leave it at that, do we? Like you say, the iceberg comparison is really handy, isn't it? The top of the iceberg, the bit bobbing above the water, is the proteins you can measure in the blood. But there's some hiding beneath the surface because you can't ever get rid of myeloma. And so even if your protein's gone away to zero and your light chains are normal, patients still benefit from the transplant to bring the levels down that we can't pick up on blood tests, but we know the myeloma is still there, to bring them down further. And then after the transplant, and as you say, Jam, after you've had a chance to recover at home, you get a bit more of the treatment you had at the very beginning, those cycles I referred to. But instead of the cycles being called induction, because they're not inducing control, they're called consolidation because they're consolidating the control. And then you just get 2 blocks of that treatment, so 2 lots of 4 weeks, to hopefully push things down even further. So you're really trying to make the most of the great ground that you've gained already. The paraprotein's gone from, let's say, 20 to 10 to 5 to 0. You have a transplant, it's still 0, but you still need more to get it down to an even lower level, even though you can't measure that level. And that's consolidation.
It can be a hard sell sometimes. It's like people say, what? Come on, seriously? You gave me 16 weeks and then I've just had a transplant and now this as well. And you tell me you can't see the myeloma. It's like, come on, doc, I've got things to do. I need to get back on the golf course or, look after the grandkids. It's like, yeah, no, I get it. But the other thing is that after a stem cell transplant, the immune system is slightly different. There is a thought that the chemotherapy works in a slightly different way, even though it's the same drugs. You get a slightly different, maybe immune modulating effect as well, which is beneficial. And we know with the way in which treatments have been developed in clinical trials that people who do best do have these blocks of consolidation.
Definitely. Yeah. And we're very grateful that we're able to prescribe this consolidation, because actually it's only relatively recently we've been able to do so, because all the trials have come through and shown that, if you give a bit more after your transplant, people do even better. And we know by then as well, importantly, which drugs the patient can cope with, what side effects they got. So we know what to look out for. So we can adapt the treatment to suit the person whilst hopefully they still get the benefit from it. Really important to say that.
So after consolidation treatment, assuming the myeloma is well controlled and people are doing well, then you enter a phase of treatment called maintenance. So maintenance therapy typically has been a tablet, and that tablet is called lenalidomide, that is given essentially to maintain the response. So that's what maintenance means. The cancer is in remission and myeloma response is maintained by lenalidomide. But we also know that people in maintenance can also improve their remission status. So the disease can be further controlled to even lower levels. Typically, this maintenance period can go on until the disease becomes more active again. So there are groups of people that stay on maintenance for a number of years potentially.
Definitely. And that's a really important part of the treatment pathway. It goes back to my previous point. You kind of want to make the most of all the hard work you've already put in by keeping the disease under control for as long as you possibly can. And that's what maintenance does, without hopefully all those more complex drugs. Just one drug, tablet, you take at home, so it's easier to cope with, hopefully. You don't perhaps need to come to clinic so much. You don't necessarily get that whole range of side effects you may have had at the beginning. So hopefully it's compatible with living a good life, a healthy life, but also controlling the myeloma.
Just summarise for our younger, stronger, fitter patients who can tolerate more intensive treatment, our aim is to push the myeloma down to an undetectably low level and keep it there. And we do that broadly with around 16 weeks of initial induction chemotherapy. Then their stem cells are collected and they have a stem cell transplant. That's 3 to 4 weeks in hospital generally. Then they recover, have 2 cycles of consolidation chemotherapy, which is another 8 weeks of what was given initially. And then after that is maintenance treatment. We know for people who go along that pathway, who get to an undetectably low level of myeloma, they will have a number of years of excellent disease control.
Yeah, Yeah, generally. I mean, I think, God, Jam, just hearing you say it like that so clearly makes me think, my God, it is mind-boggling, isn't it? All
It's
these
a lot,
different
isn't it,
terms
as well?
and
Yeah.
like, when is this going to end? I need more. Oh my goodness. But just I would say to everyone who's listening, don't worry so much about the terminology and don't worry about absorbing all of this from the outset. Your team will guide you through it as you go along, and hopefully you'll reap the benefits as you see those protein levels come down and you begin to feel better. It's all about the end game, I would say, and the end game is controlling the myeloma and living well with it.
What we know now is that there are groups of people that maybe need slightly less treatment, but for so many years, we had limited numbers of drugs and people would relapse quickly. And that's why treatment has evolved the way it is. But for certain groups of people now, there's active research at looking at shortening the amount of total treatment. And that's something we are going to come back to again and again on this podcast, because it is really exciting.
Oh my God.
I mean, for example, there may be groups of people that don't need more than a defined period of maintenance, right, Sally?
I can't wait to confuse everybody with all of that information that's coming soon. But yeah, definitely, we lump people with myeloma together. But I think when you look at how the disease behaves in different people, you might be able to say, well, actually, this person might need more treatment, person might need less treatment. And that's beneficial because then you really are modifying the treatment to the disease and also, hopefully, to the patient's wishes as well. So I think that's the new frontier of managing myeloma is stopping and starting in the right person according to their wishes and what you understand about their disease.
Right, so let's go to our bigger group of patients, the patients that are not suitable for stem cell transplantation. It's probably about 2/3 of our patients. So broadly, Sally, what's our treatment approach to them? Because I think it's important to say you can't just think of that group of patients homogeneously either, can you?
No, you definitely can't. There are numerous options available, particularly here in the UK, to offer patients of an older age. But by and large, actually, I think most patients are now receiving a treatment which involves 3 drugs. And again, you start that, but instead of having that slightly confusing induction, transplant, consolidation, maintenance, you basically start this treatment and you continue with it. And you continue with it until your disease comes back. Albeit that you may, it's very, very likely that you'll modify some of the drugs and in fact stop at least the steroids anyway after you've achieved a good remission. So it's a bit more of a straightforward path in terms of understanding what's happening. Although I say that one of the drugs, the injection under the skin called daratumumab, initially you have to have it every week for 8 weeks and then it's every fortnight for 8 doses and so on. So the frequency at which you receive the treatments can also change as you have that treatment.
So for the group of patients that are not going to go down that stem cell transplant route, I think we all appreciate there are some people that are within that fitter and stronger, and your aim in them is in a way a little bit similar to the younger group of patients, because you do hope to get them to that point of undetectable disease, if possible, and keep them there. For older patients who may be frailer, a term that we use to indicate that they picked up some diseases of aging and have maybe other health problems, sometimes symptom control of the disease and minimizing toxicity is the most important thing. That may well continue to be done with, as you say, Sally, treatment that carries on until it stops working. But for some people, and certainly towards the sort of the more extremes of age or who have other health problems, it may be that you have to stop after a defined period of time and then think about restarting treatment as and when the myeloma becomes more active in the future.
These are really interesting points. And what's interesting about it is this is an area of intense sort of research activity at the moment. Not least actually shout out to the UK researchers really, who did a big study in the UK looking at this older patient group who might be less fit and saying, okay, well, we can give some people the standard recommended treatment, and that's the standard doses according to what their doctor might wish to give to them. Or we could perhaps lower some of the doses of some of the treatments according to how fit they are or frail they are. And what was found from this study, which has recently been reported at one of our international meetings, is actually if you modify the doses, and by that I mean give people who are less fit a lower dose of treatment, they can fare just as well. In fact, they might stay on treatment for longer. So less treatment isn't necessarily a bad thing if it still works and controls your myeloma. And so I think there's a rationale. The logic for continuous treatment holds true in so much that you want to control the disease and maintain that control. And one of the standard ways of doing that is staying on therapy. But for some people, the right thing might be to give them a pause, particularly if that's their expressed wish. Or for some people, it might be to keep them on a treatment, but a lower dose of treatment, which they can tolerate, which you know will stand them in good stead in the long run. So it's an evolving area. It's not straightforward. I always say this, but I'm sure you'll agree, Jam, the patient's voice is paramount in terms of figuring out what the right approach is, and us also understanding, again, what's going on with their particular type of myeloma.
Because whatever we want to do, we want people to live longer and live better. And certainly for years in myeloma, the way to live longer was absolutely to give continuous therapy. And it is still the standard of care. And I think that point should be made. But with increasing numbers of people who have other illnesses, who are older, in their 80s or even in their 90s, as you say, listening to what's important to them is so important. For some people, even coming in monthly may not be something they wish to do. And then it's about having a discussion about, yes, we can curtail your treatment, but this is what it might mean for you in 1 year or 2 years or 3 years, which may be the right time horizon, compared to our 45-year-old who we're thinking, I need to push you a bit harder. I'm sorry, because I know that if I get you and keep you at an undetectably low level, hopefully you're going to stay in a good remission for many years and be thinking about your 6th and 7th decade. And these are the kind of things that we think about all the time in clinic and are discussed regularly at meetings.
The other thing which is different from even like 5 years ago, and I suspect this is true in the UK, but indeed all over the world, this is not a make or break situation. In so much that we know the drugs so much better now, we know how to cope with their side effects, but crucially, we also know that when the myeloma comes back, there are still options. And so it's not a case of you've got to make the most of this treatment because if you don't, it's going to look really difficult for you in the future. That's not the case. It may be that some people want to pause treatment for whatever reason. It's totally up to them. But we know that if we monitor them carefully and when the myeloma comes back, we get on top of it quickly, we can have other conversations with them about other treatments. So it's not a deal or no deal situation, which I think helps. So Jam, if I was to summarise what we've just spoken about, we've covered quite a lot of ground. We are aware that there's a lot to get your head around in this subject area. But if I can ask you to summarise the younger patient pathway, the fitter patient pathway, can you just remind us what that looks like?
People have generally around 16 weeks of what we call initial or induction chemotherapy. Then there is stem cell mobilization, where stem cells are collected and frozen. Then there is a stem cell transplant, where a powerful chemotherapy drug is given. And then those stem cells are defrosted and returned to the patient, allowing the patient to tolerate the transplant and allow the bone marrow to recover. Then there are 8 weeks of further chemotherapy called consolidation, which are the same drugs that were given before the transplant. And then people move on to maintenance treatment.
Brilliant. And I've got the slightly more straightforward job of describing the pathway in older people or less fit individuals. And that tends to be simpler, and it's a 3-drug combination. Again, you have the treatment in cycles or blocks of treatment, and you have that continually. And it may be that some of the drugs are tapered according to how you're feeling or coping with them or how well they're working. Some of them might be stopped. And again, you stay on that continually until the myeloma returns.
What's really exciting is that there's some 4-drug combinations coming for this group of patients as well. And there may be a select group of patients in some parts of the world, depending on where you live, that may be able to access that kind of treatment. But we appreciate that that's not suitable for all people.
Definitely. There's so much diversity in all of the patients and the individuals that we look after, that choosing the right treatment for the right person at the right time is what it's all about.
And of course, the bone strengthening injection given once a month, running alongside as per our last release last week.
Let's not forget that. So that was last week. This week we've done a nice overview. What's coming up, Jam, in the next couple of weeks?
This podcast today, I think Sally's going to act as a scaffold, and we're going to get into the details of the combinations of drugs that are used. We're going to have a whole podcast on what stem cell mobilization is and how it works. We're going to have a some podcasts on stem cell transplant, and we're going to get a transplant expert nurse to come and talk about stem cell transplant. And then we're going to have a pod on maintenance as well. So all these blocks that we've talked about, we're going to do some recording on. So yeah, it's really exciting to hear all the plans for the next few weeks, Sally.
Yeah, absolutely. And we'll also do a separate piece as well on that transplant ineligible pathway to those older patients and what that could look like as well. There is going to be a bit of overlap, but hopefully it'll be useful that people can say, that's relevant to me or to my relative or to my friend, and listen to the most relevant piece of the recordings.
Brilliant. Well, Sally, as ever, great discussion today, and look forward to catching up with you next week.
Nice to see you, Jam. Let's hope the sun comes out again soon, and take care.
Bye. This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.